Thanks so much, Michael. Thanks so much, Cody. It's truly a pleasure to be here, and thanks so much for the nice introduction also. My name's Burkhard Jansen. I'm a dermatologist by background, and it's just wonderful to see how far we've come and to see all you in the audience and to have the privilege of introducing the very first session of the day. In melanoma, for far too long, biomarkers were synonymous with BRAF mutations. However, today, the biomarkers to guide clinical decision-making is expanding dramatically. And you will hear in the lecture that'll start virtually right after my brief introduction, you'll hear a lot about biomarkers on the treatment guidance side, and it's for sure incredibly exciting to see all the progress we've made in terms of basically moving melanoma to response rates around 50%, sometimes even higher than that. However, I think the folks in the audience would probably very much agree that that is absolutely remarkable. However, you know, what's better than a 50% response rate? It's not getting melanoma in the first place, or it is catching melanoma early. And, you know, biomarkers haven't really moved into that area all that much. Michael mentioned some examples, but biomarkers are now really used, you know, at one end of the spectrum on the treatment side of things. We talked about that. Biomarkers are also used to help with you know, solidifying diagnoses on challenging cases after a biopsy had occurred, on tissue blocks. And even earlier than that, that's what Michael mentioned, biomarkers are starting to play an increasing role in at the very, very early stages where a patient shows up at a dermatologist's office with a mole that's concerning, and up to now, you know, with all kinds of additional technologies from dermoscopy to clinical evaluation, in many cases the next step was to biopsy that lesion. And biomarkers have really progressed to a level where we can now use stickers that we put onto those moles of concern to basically guide biopsy decisions, to triage lesions into two buckets, the ones that can be safely monitored and the ones that need the biopsy. And who likes to be cut? We of course don't want to miss stuff, but you know, again, I've been both a patient and a dermatologist. I think it's fair to say that nobody likes to be cut if being cut can be avoided. Today, we are really lucky to introduce a true expert in the biomarker field. I have the pleasure to introduce Dr. David Polsky. Dr. Polsky is a professor and physician scientist at NYU, at New York University. And his research and his laboratory work, his clinical practice, his teaching activities are focused on melanoma and atypical nevi. You know, he uses the stickers we just talked about, but his talk today will really primarily focus on the overall goal of communicating biomarkers on the prognosis and therapy side. And with that, it is again a true pleasure to introduce Dr. David Polsky. David, I don't know whether you are dialed in or not, but we are excited to hear from you. Thank you very much.
it's really an honor to be speaking with you today. I want to thank the organizers for the opportunity, and sorry I can't be with you there in person, but hopefully next year. I was asked to talk about biomarkers, and I thought the best way to talk about them was to try to frame how they can help patients. So I do have some industry relationships. My laboratory does do contracted biomarker research with Novartis and Bristol Myers Squibb, and we receive in-kind research support in terms of reagents and equipment from Bio-Rad Corporation. So as an outline, I thought I'd talk about some biomarker basics and then talk about an example biomarker, which is quite successful, I believe, which is called Oncotype DX, which is for breast cancer. And then with that as background, go into where we're at with melanoma biomarkers, both tumor tissue-based as well as blood-based. So when we think about biomarkers, one thing to think about is, well, how's a biomarker different from a clinical endpoint? So a clinical endpoint is defined as a characteristic or a variable that reflects how a patient feels or functions or survives. And in cancer, our main, one of the main things we look at is survival. So that's what a lot of the biomarkers are focused on. Clinical endpoints is survival. So it's usually related to a desired effect. So for example, the efficacy of a drug in prolonging survival. And again, survival is the clinical endpoint. Biomarkers are defined as a measurable characteristic that indicates a biological or pathogenic process. And broadly speaking, it could be an environmental exposure or response to a therapeutic intervention, such as a drug. And a biomarker is expected to predict a clinical effect. It can predict a clinical benefit, such as longer survival, or it could predict something like toxicity. And it can also be a surrogate marker of treatment benefit, and I'll mention that in a specific instance later on. Now, we often hear about predictive biomarkers and prognostic biomarkers, so I thought I would just lay these out for you. Prognostic biomarkers inform the likely disease course in what are called untreated patients. But in melanoma, we're not thinking about untreated patients. We're really thinking about patients who have all been treated surgically, and then what happens next. So you can imagine in this group of individuals here with green, red, or blue color, these are, say, all melanoma patients who've had their initial surgery. And now do we have a biomarker that can figure out who are the blue and red individuals who will recur, unfortunately, after their surgery? What can we measure in the patients or in their tumors that can help us identify who these people are, and maybe we can do something about it? And then a predictive biomarker is something that identifies a subpopulation of patients most likely respond to a given therapy. And very simply, we have a very good predictive biomarker in BRAF mutation testing, because we know that if we give BRAF inhibitor therapy to a patient with a BRAF mutation, they're likely to respond, whereas if we give that same treatment to a patient who doesn't have the mutation, they're not going to respond. So you can imagine here is this group of patients with recurrent melanoma. We need a test to identify the patient, let's say, is the blue patient who's got the mutation, and now we can predict that that patient will respond to the treatment. And this biomarker is so good that we don't even offer the treatment to patients unless they have the mutation. So it's so simple and so effective, we almost don't even think about it as a biomarker, because really what we'd like to do is say, okay, among all these patients with the mutation, who will do better or who will do worse? That's another level of prediction that we're all aiming for. So how do we develop biomarkers? Well, it's quite similar to drug development. So in drug development, we have to look at safety, and that's in what are called phase 1 trials. And then we look at efficacy, which are in phase 2, and then finally in randomized phase 3 trials, where one drug is compared to another or to a placebo if there's no existing standard, to show that there really is a true benefit over the current standard of practice. And then drugs become available to the general public once FDA gives their approval, and then payers decide to pay for it. And this is dependent on these large prospective randomized controlled trials, these randomized phase 3 trials. Now, with biomarkers, it's a similar kind of paradigm. We first talk about clinical validity, which is, does a change in the level of the biomarker associate with a meaningful clinical characteristic? So for example, I'm going to talk later about tumor thickness, and we know that thicker tumors are associated with a greater chance of recurrence. So that's an example of a validated clinical biomarker, which is actually part of the staging system. Clinical utility is an extremely high bar, and that's kind of the equivalent of efficacy for a drug, clinical utility for a biomarker. And what it means is that the biomarker readout, okay, the measurement that you get actually impacts the outcome of the patient. So in order to really demonstrate efficacy, you have to prospectively enroll patients and then do something to their treatment based on the biomarker result. So that's a very high bar, and many biomarkers can't quite get above that bar, but some have. Other considerations are safety, just like in drugs. The question is, can a biomarker cause harm to my patient? You might think, how could that possibly happen? But misclassification is an important thing to consider, and we'll talk about that, I think, on the next slide. And then in terms of availability, well, biomarker tests are what are called laboratory developed tests for the most part, and generally don't require FDA clearance, and that's a very rigorous and expensive process. And there's pluses and minuses to whether or not biomarkers require FDA clearance. Most of them don't. So it's really based on the strength of the clinical evidence, whether physicians are adopting biomarkers, whether medical society guidelines are supporting them, and other health system factors, such as whether one payer pays and another doesn't pay, sort of market forces. So for physicians, physicians need to consider, well, was the test developed in the what's called intended use population? So just like with drugs, we have for melanoma, we have drugs in stage 4 that were then developed for that were then used for stage 3, but they weren't used for stage 3 until they were actually tested in stage 3. So the same thing with a biomarker developed in one population has to be tested in the population that it's being intended to use for. Has it been validated in a prospective cohort? And this is actually quite a difficult process. So many biomarker data sets are retrospective, and unfortunately, that doesn't necessarily reflect clinical practice. So if you just look and say, well, what do I have in the pathology archives? And now let me go look at the charts of the patients. Oftentimes you're missing data that you need for your analysis, and that can complicate things. And oftentimes you maybe just get patients who are either sicker or have a worse disease than the typical patients that come through every day, and your test may not perform properly. So it really needs to be performed in the setting in which it's going to be used every day with patients who are going to do well and not going to do well, in the proportion that you're likely to see them. What could the test actually add to our management? What do we do with a positive or a negative result? Well, I mentioned BRAF testing. That's really easy to understand, but the same thing applies for other not so straightforward biomarkers. And as I mentioned before, do no harm. Misclassification such as false negative. For example, let's say a patient has a BRAF mutant tumor and you're tested and pick it up. You would never give them BRAF inhibitor therapy that they might derive a benefit from. So that's a potential harm. Likewise, a false positive. Let's say a patient has a low risk tumor, but you predict that they might be at high risk for recurrence. You can create a lot of anxiety in the patient. So we don't want to do that either. So misclassification is quite important, and we have to be not harming our patients and be aware of the potential harm. So I mentioned the Oncotype DX for breast cancer. This measures gene expression of 16 cancer-related genes and 5 reference genes. It reports out a score from 0 to 100, and it estimates the 10-year distant recurrence risk. So this is patients who've had breast cancer removed, they have no disease elsewhere, and then you look at the tumor tissue and do this test and come up with a score. It's been validated, and it's, again, not an FDA-approved test, but it's been developed in the laboratory. There have been more than 12 prospective studies since 2004 with nearly 12,000 patients, probably more than that now. So this is a very, very well-studied test, and it is not only prognostic, it's also predictive, and I'll show you here. So this was a study, 668 patients, and they all were receiving adjuvant therapy. And then they said, well, how does the score, what is the what is the prognosis of these patients? So let's just look at everybody and how does the score associate with the outcome? So if they had a low recurrent score, they had a low risk of a 10-year recurrence. 6.8% of those patients recurred at 10 years in that low risk group. In the high risk group, 27% of the patients recurred. So you can see the test actually was able to identify the patients who were more likely to recur. And this was highly statistically significant. But the more exciting use of the test was as a predictive marker for treatment benefit. This was a test of clinical utility, as I'll explain. This was the Taylor X trial, 10,000 localized breast cancer patients. And the question is that, what do you do with patients with this intermediate risk score? So the patients at high risk get chemotherapy as well as endocrine treatment. Patients in low risk get endocrine treatment only without chemotherapy. But in the intermediate group, the question was, well, is there really a benefit to chemotherapy plus endocrine or not? So what they did was they took these patients, they all had the Oncotype DX, and then they said, let's take the intermediate group as a single group, and now let's randomize them to chemoendocrine versus endocrine alone. And what they found out was there was no benefit to adding chemotherapy, and that was really a huge impact because about 85% of breast cancer patients fall into this intermediate risk group, and now you can spare those patients the toxicity and side effects of the chemotherapy, and they just need to have endocrine therapy, and they'll do just the same. So this was really a big impact that really relied on the biomarker to be able to do that study. So moving on to melanoma biomarkers, there are biomarkers for localized disease, and they form the backbone of our staging system. And then there are some commercial molecular tests of tumor tissue. I'll talk about one of them. And then in metastatic disease, there are tumor-based biomarkers. I mentioned BRAF mutation testing. I'll mention another one as an example. And then there are blood-based tests, including lactate dehydrogenase, which is secreted by tumor cells and is part of the staging system. And then circulating tumor DNA, which is an area of excitement in many laboratories around the world, including our own. So I thought I would share some of the data on that as well. So looking at localized disease, tumor thickness and ulceration are really prognostic biomarkers, and that's why they are in the staging system. So this is a bit of a complicated slide. I'll take you through it. Basically, what you're going to see is different clinical stages down here on the side, and then in here is going to be what the pathologic findings in the tumor that define these clinical stages, and then survival in both the 7th edition and the 8th edition of our staging system. This is the most recent edition, which has some very important modifications that improve the accuracy. So, so here, stage 0 melanoma is in situ. It's basically 100% of those patients are cured by surgery. Stage 1A are thin melanomas, less than 0.8 millimeters, not ulcerated. In the 7th edition, they scored mitoses. We no longer do that. In the 8th edition, the 1B tumors are basically ulcerated thinner tumors or non-ulcerated slightly thicker tumors. And what I want to point out here is the survival difference. So you can see here between the 7th edition and the 8th edition, the 5-year survival went to 97% for this stage 1B, for example, compared to 92%. The treatment didn't change. But what happened was all of the patients who were included in the 8th edition had a sentinel node biopsy. And if they had a positive sentinel node, they were immediately put into stage 3. So you have a much more pure population of patients here in stage 1B. And you can see at that point now, the real survival for people with localized stage 1B melanoma is 97% at 5 years compared to 92%, where you had a mixture of patients who had nodal disease that was undetected, but they were actually in that group. Now, the reason I mention that, here's the rest of the staging system, and I know it's very busy, but these are basically thicker and more ulcerated tumors as you advance from stages 2A to 2C. You can see the real benefit of the nodal staging by improving the survival in stage 2. So whereas stage 2A was 81% 5-year survival, in the 8th edition is 94%. So why do I show you all of these numbers? Well, the idea is, well, where do we need prognostic biomarkers? Well, in stage 1, most patients, the vast majority of patients, are cured by their surgery. So the existing biomarkers are really quite good. Now, I know we all have heard stories about patients with thin melanomas melanomas who had a recurrence and perhaps died from their melanomas late, but it's extremely difficult to develop a biomarker when out of every 100 patients you enroll, maybe only 3 or even 5 patients will recur. You need large numbers of patients to develop a biomarker, and it's just really prohibitive. In stage 2, there's a much greater need because you can see even with the improved staging system, there's still a substantial fraction of patients who are going to recur and some are going to pass. So we really can benefit from having biomarkers for stage 2. So moving on to molecular tests, I'm going to mention the Castle Biosciences DecisionDX test because it's quite well known at this point. It is a prognostic test for primary melanomas, similar to Oncotype DX. It measures gene expression and associates that with 5-year survival. It reports out as low risk and high risk, basically. It's commercially available. It is reimbursed by Medicare at a cost of $7,200, which is really quite expensive when you consider Oncotype DX is only $3,400. The intended use is, once you get the result, is to help decide whether or not to get a sentinel node biopsy or not, and then what level of follow-up imaging and referrals are appropriate. So what is the evidence behind DecisionDX? Well, unfortunately, most of their data are retrospective studies that were from available tumor samples in archives and then chart review of patient data. And as I mentioned before, patient selection may not actually, in these settings, may not actually reflect actual practice. So while it's fine to do this for initial clinical validation work, I believe prospective data are really what's required. And if we look at one single center retrospective study between 2013 and 2019 that was just published with 361 patients, and this was from an institution that this was not a sponsored study, so I think it's an independent look at the test. The patients that were categorized as high risk by Castle were more likely to have the higher stage tumors, so that makes sense. But when they said, did the Castle result improve the prognostic accuracy of the staging criteria of tumor thickness and ulceration, there was no improvement in their prognostic modeling. So the conclusion here, I think, is that we really need prospective data to really properly validate whether the test is useful, because this study so far is not really supporting the use of that test. Now, it turns out there was a prospective study done a few years prior, much smaller, 159 patients, and I won't go through the details, but 96 of those 159 patients were stage 1, and unfortunately there was no benefit in any of those 96 patients. All they had was a few that were positive and they were misclassified. There were 40 stage 2 patients, but that's really quite a small number when you think about like Oncotype DX, where the smallest study had well over 150 of the intended use population, and many had thousands. So this was quite small, and half the test results were false positives. So there's a potential harm there. So the conclusion is, I think that it's not useful for stage 1 patients based on this study, prospective study, and that further validation in prospective cohorts is needed. And I really think the focus should be stage 2, as I mentioned before. And I'm not the only one who thinks this. The National Comprehensive Cancer Network guidelines say that routine testing is not recommended outside of a clinical trial. So moving on to metastatic disease, we'll talk about tumor-based and then blood-based biomarkers. So you may have heard about PD-L1 expression measured by a technique called immunohistochemistry. And let me give you a little bit of a way to understand this. Anti-PD-1 therapy are these antibodies that basically block the binding of two molecules, PD-1, which is on the surface of the tumor cell, and that's kind of like an off switch for the tumor, for the T cell. So the immune cell puts out PD-1 sort of as an off switch, so it doesn't overreact, and cause things like autoimmune disease. It's a way that the body regulates itself. Tumor cells have gotten, unfortunately, very smart, and they put up another molecule called PD-L1, and that binds to PD-1 and basically flips the off switch to shut down the T cell. So what's so effective is the PD-1 antibodies block this interaction, so the off switch doesn't get flipped and the T cell can continue going on killing the tumor cell. So you might predict that if you have a tumor that expresses a lot of PD-L1, that these antibodies will be very effective because they're blocking this interaction. And this is an example here on the right. Under the microscope, you can see the blue cells, and the brown stain is a way to detect that PD-L1. And you can see that this is very positive with a lot of brown staining. And here's 4 examples with lesser amounts of brown staining, lesser amounts of PD-L1. Well, it turns out that these patients whose tumors have these higher levels do have higher response rates and somewhat better survival. But it turns out that even patients who are negative can still respond to the antibody, and some have durable responses. So in looking at the data altogether, because there aren't so many options for melanoma, and because some of these patients can still have durable responses to their PD-1 therapy, that this biomarker was just not sufficiently predictive to impact clinical practice. So we do not use this to figure out who should get PD-1 therapy or not. So you can see the high bar that's needed to really incorporate a marker into practice. Now, there are other exploratory markers, such as how many infiltrating lymphocytes there are, expression of things like gamma interferon, which stimulates the immune system, and how many mutations are in the tumor, because mutations can be targets of the immune system. But none of these are really ready for clinical use. Now, with respect to blood-based markers, lactate dehydrogenase is secreted by tumors, and with high levels, patients do have a worse outcome. So it's part of the staging system, and this is the nomenclature for the staging system. But what I want to show you here is sort of an example of how this plays out. We know that elevated levels of LDH prior to starting treatment are associated with a shorter survival in both BRAF MEK inhibitor and immunotherapy clinical trials. So here's a survival analysis. This is the patients, the percentage of patients who have not progressed on treatment. So you start at 100%, and this is the months since they started treatment. So at time 0, everybody's not progressed, and then with treatment, some will progress. And what we do is we draw a line at 50%. So at what point in time have 50% of the patients progressed? So you can see if you have an elevated LDH, you have the purple curve, and by about 6 months, half the patients with elevated LDH have progressed. But if you have a low LDH, or normal LDH, I should say, then it's not until 18 months that half the patients have progressed. So you can see how LDH as at baseline is identifying patients who are going to do better or do worse with the treatment. Now, it's an interesting clinical utility test going on in the Netherlands, what's called the Cowboy study. The idea is that you can give patients with BRAF mutant melanoma BRAF MEK inhibitors, here vemurafenib, cobimetinib, to normalize LDH. And that's because LDH is thought to be a surrogate marker. As I mentioned, it's kind of meant to reflect how much tumor's in the patient. And then after you hopefully normalize the LDH, it's basically moving people from the purple curve to the red curve conceptually, then give them nivolumab and ipilimumab. Maybe they'll do better than if they just started with a high LDH. So we'll be interested to see the results of that study. There are other exploratory biomarkers, such as different cell subsets and something called C-reactive protein, but also not ready for prime time. So in the last few minutes, I just want to talk about self-recirculating tumor DNA, which I mentioned is really quite exciting area in many cancers, but in addition to melanoma. Here's a cartoon showing basically a blood vessel, and that DNA, which is normally within the cells, and here's the tumor cells, it gets released into the bloodstream free. So it's outside of we're not talking about circulating tumor cells, we're just talking about free circulating tumor DNA. And that's from dead and dying tumor cells or inflammatory cells that release their DNA into the bloodstream. And we see increased levels in cancer patients and patients with inflammatory diseases. And it's a biomarker in that you can detect mutations from the solid tumor just by looking at the DNA in the bloodstream, and you can even characterize treatment resistance mechanisms based on mutations, and that's being done in lung cancer. You can adjust treatment based on a blood test instead of getting a lung biopsy in patients who have a follow-up on treatment. And very exciting, can be used for disease monitoring. It's a lot easier to get a blood test than going for a CAT scan, for example, and you can do it more often. So it's being studied as a pre-treatment and on-treatment monitoring tool, and I'll show you some data there. And also, there's a small study from Manchester in the United Kingdom, and I don't know if they've reported the results yet, but they wanted to treat patients with BRAF MEK inhibitor therapy, obviously BRAF mutant patients. And when they got to an 80% reduction in ctDNA, meaning that they've knocked down the tumor burden, then they then give them ipi-nivo. So sort of similar to the cowboy study, but here using ctDNA to then do the treatment switch and waiting until they got the 80% reduction instead of just doing it at 6 weeks. So just to show you what some of the data look like and why we're so excited about it, this was a study from our laboratory published last year, looking at patients with BRAF MEK inhibitor therapy and on treatment and pre-treatment ctDNA monitoring. So basically what I'm showing you here is progression-free survival and overall survival. And this is looking at ctDNA levels baseline, and we were able to derive a cutoff value and validate it, which I'm not showing the validation data here. But basically, if you look here on the green curve, these are people who started off with a low ctDNA level at baseline, less than 64 copies per mil, and you can see their survival is much better than the patients who had a higher level at baseline, and that translated in overall survival to 3 times longer survival if their ctDNA was low before starting treatment compared to high, 35 months versus 13 months. We then looked at what happens at 4 weeks. We had a 4-week sample, so patients start treatment, and many of their patients that we see a dramatic drop in ctDNA, and if you became undetectable below the limits of detection of the assay, you're on the red curve here. Here's overall survival on the right, but if you did not achieve undetectable levels, if you still had detectable levels, your survival here is on the blue curve, and here was about a doubling of survival. So patients who achieved undetectable levels had about a 28-month median survival compared to 14 months here. So we think that ctDNA monitoring could be an early indicator of treatment effectiveness and potentially also be used to guide therapy as those other trials are looking at. This is from an Australian group looking at the response to anti-PD-1 therapy. You can see here the survival curves. 3 groups. The green are people who had undetectable ctDNA at the start of treatment, and it stayed undetectable throughout treatment. And that's this busy box up here. Each column is a patient. Green is undetectable. Blue is missing data. But basically, everybody's green on the screen for the whole duration, and they had the best survival. So they always had undetectable ctDNA. The blue had the next best survival. That's this group down here. They had detectable levels at baseline down on the bottom row. And then as treatment went along, you could see by 5 to 6 weeks, everybody had undetectable levels, similar to what I just showed you from our study. And they had also very, very good survival. And the patients with the poor survival here in the orange are here on the right. They had high levels at baseline, and you can see whenever they had a sample available, those were still high levels. So they failed to become undetectable, similar to what I showed you before. So I'll stop here and basically remind you that we talked about biomarker development being similar to drug development. Demonstrating clinical utility requires multiple validation studies in large prospectively accrued patient cohorts. And biomarkers demonstrating clinical utility have improved the care of cancer patients. I showed you the example of Oncotype DX. Several tissue and blood-based biomarkers for melanoma show clinical promise, but few have really advanced to the level of clinical utility. So thank you for your attention, and I'm happy to answer questions.
And I think as all of you can see, David is now full screen and ready for questions. We got Cody with the microphone over there, me with a question here. Say your questions clearly. He can't see you, but he can hear you. Is there anyone who would like to pose a question on biomarkers? Yeah, got that one. David, thank you for a great talk this morning, afternoon.
Very welcome. My pleasure.
Is his sound hearing?
Michael, can you hear me okay?
Good morning. Thank you for your talk. At one point during the talk, you mentioned that to validate the biomarkers, you need a large number of patients to enroll in the studies. And so with some of these more rare subtypes of melanoma that would be hard to come by with large numbers, what kind of ballpark would you need to come up with a valid biomarker and to really understand if that's valid?
So that's a great question. And I'm assuming you can hear me okay. It really has to do with what we call the effect size, or the strength of the biomarker to classify patients. And I'll use an example that I hope won't seem trite, but people talk about randomized clinical trials to prove, for example, the effect of a drug. And there was a famous quote someone once said, "You don't need a randomized clinical trial of a parachute, right? Because you know that it's either going to work, and the person jumping is gonna survive most likely, or they're not." So that has what we call a very large effect size. So you need a very small sample size. You know, 1 or 2 people, right, for the study of the parachute. Of course, never going to do that. So if you have something that's really a powerful biomarker, which unfortunately are hard to find, you really don't need very many patients. So the sample size really depends on the strength of the association. So if you have a biomarker that really identifies the responders versus the non-responders, or the people who have minimal residual disease after their surgery or not, and it's very sensitive and very specific, you don't need a lot of a sample. But typically we're talking hundreds, I would say, is a reasonable number for the kind of average biomarker.
Great, and we have another question here.
Thank you for a great talk.
Thank you.
Among different markers, you didn't mention circulating tumor cells. Why? It's some reason?
So circulating tumor cells in melanoma have been studied for a long period of time, but part of the problem is they're quite rare. And in other cancers where circulating tumor cells have become a bit more integrated or a bit more advanced, it's because there's a surface molecule on the tumor cell that we have an antibody to, and that antibody can basically bind to that surface molecule. And when you bind the antibody to, say, a magnetic bead or column, you can take the blood sample and run it through that process, and the antibody captures those cells, and then you can analyze those cells. We don't really have a good antibody capture methodology for melanoma, so we rely on other things like size differential or other methods, and it just hasn't really been reproducibly useful. So there's not as much really out there for circulating tumor cells in melanoma.
We're going to one more question, and
So I'm a mucosal melanoma patient, and we have low mutation burden typically, but I'm concerned that some of these biomarkers are going to be used, and there's a confounding variable about how and when things are detected, because with mucosal melanoma, they tend to be detected much later. And that's a confound that's going to interact. And I can just imagine insurance companies saying, you don't get Ipi-Nivo because you have a low mutation burden, or you don't get Nivo because you have a low mutation burden. There's something a little bit confusing when it comes to comparing cutaneous melanoma to, say, mucosal melanoma. And I think there's some compounds in there that may cause some problems in terms of disentangling things. So just a question that I have for you is, how do you deal with that? Because that's not necessarily going to be detected in a trial. You have to really be aware of the compounds.
Yeah, well, you raise an excellent point, which is that it's always best to study a relatively uniform group of patients in a sense of a uniform disease category. So you're absolutely right that mucosal melanoma is different than cutaneous melanoma, far fewer mutations, exactly what you said. The ideal situation would be to study a group of mucosal melanoma patients because there's a chance that a biomarker for mucosal melanoma may be different than one for cutaneous melanoma. Just one point about the NIVO and mutation burden. To my knowledge, no one's using mutation burden as a biomarker to determine eligibility for treatment. So because we really don't have a validated cut point, for example. Many of the studies of mutation burden that show that patients with a higher or lower mutation burden, they just take they look at the mutation level in the entire study and they say, well, let's just take the top half and compare it to the bottom half and see how they do. But that's fine for what we call discovery. But to get to the validation phase, you have to really pick a cut point for the laboratory and say, okay, if you're above, 20 or whatever, and then test that cut point, because the midpoint for any given study will vary between the study populations. So I wouldn't be concerned that I would be shocked if any insurance company denied NIVO to someone based on mutation burden, because it's not a standardized assay. It's far from clinical use, to my knowledge. I mean, you may know about the approval of immunotherapy for cancers based on mismatch repair deficiency. So those patients do generate a high mutation burden, but that's a different determinant than mutation burden itself, and that's actually to allow more people to get anti-PD-1 therapy as opposed to restricting it.
All right, thank you very much, Dr. Polsky. That was fantastic.